Hello, welcome to the North Carolina Pharmacists Association webinar series. We appreciate your participation in this presentation titled Updates in Pharmacotherapy for Diabetes. Following the webinar, please be sure to follow the instructions alongside the webinar's link on the NCAP website to obtain CE. NCAP members will receive 1 hour of free NC-CE credit. Our speakers today are Dr. Batise, who graduated from Campbell University College of Pharmacy and Health Sciences in 2011. She then completed a residency with the Southern Regional AHEC and Cape Fear Valley Medical System. For the past 5 years, she has taught for Wingate University School of Pharmacy. She teaches in a variety of courses with a focus on ambulatory care-related topics. Dawn practices at Cabarrus Family Medicine in Harrisburg, North Carolina, with a passion for diabetes management. Our second speaker is Dr. Jacky Olin, who is currently a professor of pharmacy at Wingate University School of Pharmacy and a clinical pharmacy specialist with an inpatient hospitalist service at Novant Health Presbyterian Medical Center. Dr. Olin serves the American Society of Health System Pharmacists section of inpatient care practitioners as the Director at Large for the Executive Committee through 2018. She has participated on the NCAP Education Committee for the last 8 years and is a North Carolina delegate to the ASHP House of Delegates. I will now turn it over to our first speaker, Dr. Batise.
Thank you so much, Dr. Holmes. Dr. Olin and I are happy to provide this webinar this morning. And without further ado, we're going to get started on our updates in pharmacotherapy for diabetes. To begin with, Dr. Olin and I would like to make it clear we don't have any relevant financial or any other disclosures to make in relation to the content of this program. Today, our goals are going to be to compare and contrast guideline recommendations for the management of hypertension and dyslipidemia in people with diabetes. We'll then describe some of the evidence behind improved cardiovascular mortality with certain antihyperglycemic agents. Dr. Olin will then move into describing important differences between and important counseling points for some of the newer concentrated insulins. And then finally, given a patient case scenario, we're going to formulate an evidence-based treatment plan. With that treatment plan in mind, we're going to start with Mr. Jones. Mr. Jones is a 68-year-old African-American male who's been referred for diabetes management and education. He has a past medical history of type 2 diabetes, hypertension, dyslipidemia, and a history of MI at age 66. He is a current smoker. He has Medicare Part D. He's a retired teacher, and he lives at home with his wife. You can see his current medications include atorvastatin 80 milligrams daily, aspirin 81 milligrams daily, lisinopril 20 milligrams daily, metoprolol succinate 200 milligrams once daily, and metformin 1,000 milligrams BID. We have a bit of objective information for Mr. Jones as well. You can see his height and weight listed there. Leave him with a BMI of 31, so he is currently obese. His blood pressure today is 142/87, and his heart rate is 72. On the right side, you can see his serum creatinine is 0.9, and if we calculate a creatinine clearance with his adjusted body weight, we do see that that comes to over 100. And his GFR is also within normal limits. Sodium and potassium are also within normal limits, but his A1C is concerning today at 8.2%. His lipid panel is as follows: total cholesterol 162, triglycerides 170, HDL 51, and an LDL of 77. His albumin to creatinine ratio is also concerning because it is over 30. Mr. Jones does check his blood glucose at home, and you can see his fasting numbers range from about 149 to 174. He checks his postprandial values less frequently, but we do see that they are often in the low 200s. And these numbers are in line with his A1C that was tested today. So I want you to keep Mr. Jones in mind as we continue through this presentation and think about what changes you would potentially recommend to optimize his overall therapy and also potentially reduce his cardiovascular risk today. And with that, we'll begin with our hypertension and lipid guideline updates. It is important to understand why this really matters to your patient. So when we talk about ASCVD, we're referring to any acute coronary syndromes, MI, angina, coronary or other arterial revascularization, stroke, TIA, or peripheral artery disease. We know that ASCVD is the greatest contributor to both direct and indirect costs in people with diabetes, but even more importantly, it's the leading cause of morbidity and mortality in people with diabetes. We recognize that diabetes, hypertension, and dyslipidemia increase the overall ASCVD risk, So by controlling these disease states, we can hopefully prevent some of that morbidity and mortality for our patients. So we'll start with the hypertension guidelines. We see that there's 3 we can review today. JNC8 was published in 2014, and it recommends a blood pressure goal of less than 140/90 for people with diabetes, regardless of age or whether or not they have CKD. In 2015, ACC, AHA, and ASH also published their guidelines that were specific to people that have a history of coronary artery disease. And those that have CAD and diabetes, they also establish a goal of less than 140/90. However, there is a caveat that for our older patients of 80 years or more, that we may loosen that goal to less than 150/90. Annually, the ADA publishes their standards of care, and as of 2017, they also recommend a blood pressure goal of less than 140/90. However, they have an optional goal that's a little bit lower of less than 130/80. And this is something you may consider for your patients that are at a high cardiovascular risk. And also if you can achieve this without creating undue treatment burden. So we want to consider cost, we want to consider complexity of the regimen, and also if the patient can be adherent to this without developing additional side effects. According to the ADA, first-line treatment could include a variety of options. It may be an ACE inhibitor, an ARB, a dihydropyridine calcium channel blocker, or a thiazide-like diuretic. However, if your patient does have an albumin to creatinine ratio of greater than 30, thinking back to Mr. Jones, an ACE inhibitor should be used first line. Now, if that's contraindicated or cannot be tolerated, you could use an ARB in its place. When we look at the lipid guidelines, we do see that there is a little bit more variation. So starting with the 2013 ACC AHA guidelines, you may recall that this is focused on what we consider statin benefit groups and not so focused on the LDL goals that we were used to historically. They do have a nice treatment algorithm that you can follow along, and you'll see that on this left side, we start with patients that are age 21 or older and initially just determine, are they a candidate for a statin? Would it be considered safe? Are there any contraindications? From there, you then flow to the middle, and you can consider, do they have a history of clinical ASCVD? Do they have an LDL of 190 or higher? And then we also look at, do they have a history of diabetes? So there at the bottom with the big red star, you'll see that for any of our patients that have a history of diabetes, either type 1 or type 2, that are between the ages of 40 and 75, we automatically consider them for a moderate intensity statin. You can also calculate their 10-year risk score. Now, this is using the pooled cohort equation, which is a change from our previous Framingham score. And we're also going to start looking at a risk of greater than 7.5%. So if your patient has a 10-year risk of greater than or equal to 7.5%, they may actually be eligible for a high-intensity statin. Our next set of guidelines that we'll look at for lipids are the 2015 NLA guidelines. This is our National Lipid Association. And you can see that just overall, right off the bat, there are some changes here. On the left side, we see that these are now categorizing patients based on their risk score. For a person with diabetes, they automatically are considered to be at high or very high risk. The differentiation is based on their additional risk factors. So if you have a patient with diabetes plus 2 or more additional ASCVD risk factors, so you may look at smoking, blood pressure control, HDL, then they may be considered very high risk. The NLA also referred back to our LDL goals that we were comfortable with in the past. And you can see that for anyone with diabetes, their non-HDL goal at a maximum is going to be less than 130. If they fall into that very high risk category, that then drops to less than 100. The LDL goal for a high risk patient would be less than 100. For our very high risk patients, less than 70. Based on their risk category and their LDL goals, you would then be able to select an appropriate agent, starting with a statin as our first line agent and potentially considering whether it should be low, moderate, or high intensity. The 2017 ADA recommendations are somewhat of a combination of both of the guidelines that we've looked at so far. We can see that you begin by establishing the patient's age, then looking at risk factors, and then determining what statin intensity would be recommended. Overall, unless the patient is less than 40 years of age and has no risk factors, they're going to be at least on a moderate or high intensity statin, which is generally in agreement with our ACC AHA guidelines that we looked at from 2013. But the risk factors are more familiar with our NLA guidelines that we looked at. One exception here that they have added is that for your older patients, 40 to 75 or 75 years and older that have a history of ACS and an LDL of at least 50, you may also consider the addition of Acetamide. When these guidelines were published, they really didn't consider PCSK9 inhibitors, and you may be familiar, this is a newer class that has come out. It includes evolocumab, which is brand name Repatha, and alirocumab, which is our brand name Praluent. Both agents are FDA approved in addition to diet, with the use of a maximally tolerated statin for the treatment of adults with heterozygous familial hypercholesterolemia. They are also approved for the treatment of clinical atherosclerosis, atherosclerotic CVD, and in patients that require additional lowering of LDL. So that leads us back to our NLA guidelines where we are looking at specific LDL goals. Evolocumab also has an additional approval for homozygous familial hypercholesterolemia. If we're going to consider the use of these agents, we certainly want to consider what is their added benefit. We know that statins already have an established history of reducing cardiovascular risk, but what about this new class? Currently, alirocumab is undergoing study in their Odyssey outcomes trial, and that data is expected to be completed in December of 2017. So hopefully we'll see that come out in December in 2018. Evolocumab has completed their FURRIER trial. Now this trial was looking at over 27,000 patients with a history of ASCVD and an LDL of 70 or more on statin therapy. You can see that baseline characteristics, it was mainly Caucasian men around the age of 62, and a lot of these patients were fairly sick. 80% had a history of MI, 18% a history of CVA, 13% PAD, 80% had hypertension, and about a third had diabetes. Also, 28% were smokers. They generally had good background therapy considering their history. 69% were already on a high-intensity statin, and 30% were on a moderate-intensity statin. Nearly all of the patients were currently treated with aspirin, and about 3/4 of the patients were on a beta blocker and an ACE inhibitor. At baseline, their LDL was 92. So thinking back to those NLA guidelines, potentially they may need an LDL goal of less than 70 because they already have this established history of ASCVD. Otherwise, their baseline lipids included a total cholesterol of 168, HDL of 44, and triglycerides of 133. The patients were followed for just over 2 years while they were on their statin, and then they were either placed on evolocumab or a placebo. You can see the first line of this table has the primary endpoint of this study. It was a composite endpoint of cardiovascular death, MI, stroke, unstable angina requiring hospitalization, or any kind of coronary revascularization. And at the end of this trial, there was a statistically significant difference between the two groups, favorable for evolocumab. There's also a few key secondary endpoints listed there. And when you look specifically at MI alone and stroke alone, we again see that statistically significant difference in favor of evolocumab. I also thought it was interesting to note that while these patients had an LDL already under 100, for those that were placed on evolocumab, they had an additional 59% lowering in their LDL compared to placebo from where they started at baseline. So we're getting really impressive LDL lowering, but it appears that additionally we're also getting a cardiovascular risk benefit. In terms of other non-statin options, we also have Acetamide. And recently the Improve It trial was published. This trial was looking at just over 18,000 patients that were at least 50 years old with a history of recent ACS. And those patients could have had an MI or high-risk unstable angina. To be included in the trial, they evaluated whether or not they were on a statin and then looked at their LDL. If the patient was on a statin, they had to have an LDL between 50 and 100. If they were not on a statin, their LDL could be 50 to 125. These were, again, mainly white males around the age of 64. Baseline LDL was 93. About 61% had a history of hypertension, 27% diabetes, about a third were smokers, and also about a third had been on a statin even prior to their ACS event. The primary endpoint here was, again, that composite cardiovascular death, non-fatal MI, non-fatal stroke, unstable angina requiring hospitalization, or coronary revascularization within the past 30 days. These patients were initiated on Acetamide or placebo in addition to a background therapy of simvastatin 40 milligrams daily. And you can see in our chart that that primary endpoint did show a statistically significant difference in favor of Acetamide. Also, we did see some additional LDL lowering. You can see after 1 year, the baseline LDL of 93 had dropped to right around 70 in our placebo group and about 53 in our treatment group, which was a statistically significant difference and something important to keep in line if you're shooting to try to follow those NLA guidelines with our LDL goals. Also, when you look at the p-values, treatment with Acetamide did also significantly reduce the risk for any MI, including non-fatal MI, any stroke, ischemic strokes in particular, and urgent revascularization. Overall, this was also achieved without any difference in adverse events or differences in the withdrawal rate due to adverse events. So we may be able to get an added benefit without adding much risk for these patients. So with that in mind, what is the role of our non-statin treatment? Well, according to the 2013 ACC/AHA guidelines, it is reasonable to add a non-statin agent if the patient is high risk, which they considered an LDL of greater than 190, if they have diabetes, or if they have a history of ASCVD, and they don't achieve what they refer to as expected LDL lowering, or if they can't tolerate a statin. So an example of this might be a patient that you start on a high-intensity statin, but perhaps they only achieve a 20–30% lowering in their LDL. That isn't the expected amount of LDL lowering, so perhaps you should look at a non-statin agent in that scenario. However, we do want to keep in mind that new data have become available since these guidelines were initially published. So when should you consider those? PCSK9 may be considered in a patient that has heterozygous or homozygous familial hypercholesterolemia, or again, just in those patients that have high cardiovascular risk and they're on the maximally tolerated statin, but they don't get the sufficient LDL lowering. You do have to consider also if your patient can afford these agents. They are very new, very expensive. It is an injection, so it may not be the right fit for every patient. Acetamide is an oral agent, lower cost, but we should only consider this in our patients that have a history of ACS and are at least age 50 or older based on the enrollment criteria in the Improve It trial. But all in all, when you walk away today, I do want you to remember that you should always max out that statin dose first, because we do know that there is cardiovascular benefit with our statins. So let's go back to Mr. Jones. Just a reminder, he's our 68-year-old African-American male. You can see his past medical history listed there, most notably that he has diabetes and a history of MI. In terms of his hypertension, he's currently on lisinopril and metoprolol succinate. And in terms of his lipids, he's currently on atorvastatin. When we take a look at his hypertension, we'll start there. Right now, his blood pressure is 142/87. So we see he's just slightly above our goal of less than 140/90 that we see shared across all three guidelines. However, could you argue for a different goal? I think that you potentially could use that argument from the ADA that he is at very high cardiovascular risk based on his history of MI, his poorly controlled diabetes, he's a current smoker, etc. However, I would suggest before we start to look at other treatment options that we should evaluate his overall blood pressure trends and also determine, was his blood pressure correctly measured? So ask yourself these questions. Did he walk in the door and have his blood pressure measured today when he was acutely ill? Perhaps did he have a very stressful morning? We know that he's a smoker, so we'd like to be sure that he didn't have a cigarette right before he walked in the door, that he hasn't eaten or had anything to drink, especially caffeine, very recently. You may want to do a recheck of his blood pressure and give him a few minutes to sit quietly and not be talking before we really evaluate, is his blood pressure truly above goal? However, if you do all of those things and you do see that the blood pressure is elevated, then we have some options. Potentially, we could increase that lisinopril. We do know that an ACE inhibitor is an appropriate option for him because he does have that albumin to creatinine ratio that is greater than 30, indicating that there may be some nephropathy that we should be concerned about with his diabetes. We could also continue his blood pressure of the beta blocker agent, of course, because of his history of an MI. But what about his lipids? Well, we have multiple options. According to the ACC/AHA, we don't have any LDL goals to go by. So if he achieved the expected lowering after he started his atorvastatin 80 milligrams daily, we could consider that his control is sufficient. However, if we look at the NLA guidelines, we would determine that he is considered very high risk, which would give him an LDL goal of less than 70. He's already on the maximum statin that he can be on at atorvastatin 80. So perhaps we could consider a non-statin agent. As always, we would want to consider the risk versus benefit and talk to him about finances, adverse events, and his willingness to take other agents. If he is agreeable and it's determined that the benefit is worthwhile to him, then perhaps you could consider Acetamide for Mr. Jones. He is over the age of 50, and he does have a history of ACS. Looking at his overall cholesterol panel, we can refer back to our ADA guidelines. And just as a refresher, the triglyceride goal for our patients with diabetes is less than 150. He is over that at this time. His triglycerides were at 170. But it is possible that if we improve his overall glycemic control, we may get those triglyceride levels down as well. So we don't want to target those initially. Fortunately, his HDL is at goal, which is greater than 40, and he's currently at 51. So that would be something that we could encourage him with. So now that we've reviewed our hypertension and lipid guidelines, we're going to transition and look at our diabetes medications and the newest CV data that's become available. Today we're going to focus on two classes, the SGLT2 inhibitors and our GLP-1 agonists. We'll start with our SGLT2 inhibitor, empagliflozin. This was studied in our IMPA-REGS outcome trial, and it was looking at empagliflozin 10 or 25 milligrams daily versus placebo in just over 7,000 patients that had diabetes and an established history of cardiovascular disease. Specifically, that could include patients that had an MI, stroke, unstable angina, peripheral artery disease, or CAD. These patients were generally white males around the age of 63. Their A1C at baseline was 8%, and over half had a history of diabetes that had been ongoing for 10 years or more. 76% did have a history of coronary artery disease, and almost 50% did have a history of an MI. These patients were followed over 3 years, and at the top of our chart there in bold, you'll see the primary endpoint was a composite of cardiovascular death, non-fatal MI, and non-fatal stroke. That p-value shows that there was a statistically significant difference in favor of empagliflozin. When we look at our secondary endpoints broken down, we see that empagliflozin was favorable specifically for cardiovascular death alone, but there wasn't a statistically significant difference when we looked at MI alone or stroke alone. It's interesting to note that when we also look at heart failure hospitalizations, there was a decreased risk in our empagliflozin group. At this time, this is still undergoing additional study, but it's something to keep an eye on and perhaps keep in mind for your patients that do have an established history of heart failure, that you may consider the SGLT2 class 4. Based on this data, the FDA has updated the label for Jardiance, brand name for empagliflozin, and it specifically says that it is approved to reduce the risk of cardiovascular death in adult patients with type 2 diabetes mellitus and established cardiovascular disease. So that last part is what's really important to remember. This is only approved specifically for our patients with established cardiovascular disease when we are looking for cardiovascular benefit. Our next SGLT2 inhibitor agent that we're going to look at is canagliflozin in the CANVAS trial. So this is actually a composite of the CANVAS and the Canvas-R trials that were completed, and they were combined to evaluate just over 10,000 patients. These patients were either on canagliflozin 100 or 300 milligrams daily or placebo. They had to have a history of diabetes and be considered at high cardiovascular risk. So high risk was defined in two potential ways. The patient could be 30 years or older with a history of atherosclerotic vascular disease, and this could be coronary, cerebrovascular, or peripheral. Or the patient could be older, 50 years plus, with at least two risk factors. And their risk factors, according to the Canvas trials, were diabetes for at least 10 years, a systolic blood pressure of greater than 140 while taking antihypertensive medications, a history of smoking or current smoker, and an HDL of less than 38. The patients in this trial were mainly white males around the age of 63. They had an established history of diabetes on average about 13 years and an A1C at baseline of 8.2%. 67% did have cardiovascular disease. They were followed for just over 2 years, and it is important to note that these endpoints were measured as the number of events per 1,000 patient years. Since that's unique to this trial, I did want to make a note of that. The primary endpoint was cardiovascular death, non-fatal MI, and non-fatal stroke. And we can see that canagliflozin did reduce the risk of that primary endpoint, and it did have a statistically significant difference between canagliflozin and placebo. When we look at some of our key secondary endpoints, we again see that canagliflozin did have favorable results for cardiovascular death, MI, and stroke when evaluated individually. Again, we see that reduction in heart failure hospitalization, similar to what we saw in our InfoRegs outcome trial. So now we're not just seeing it with one agent, but potentially an indication that this could be a class effect overall. Also in the Canvas trial, it's important to note that there were some potentially negative outcomes seen as well, specifically in terms of amputations. Based on this data, the FDA did update the label for Invokana, which is our brand name canagliflozin, in July of 2017, noting that there is an association with lower limb amputations, especially of the toe and the midfoot, some farther up the leg. So before you would start a patient on canagliflozin, you should consider other risk factors that may increase their risk of amputation. This could include a history of peripheral neuropathy, a history of prior amputation, or ulcers on the foot. Those patients may not be the best candidates to use this agent. If a patient is currently on canagliflozin, then you should, of course, be monitoring as you would with any patient with diabetes. But if they develop any ulcerations or infections, you should stop the canagliflozin. Our final agent that's currently available in our SGLT2 inhibitor class is dapagliflozin. At this time, their cardiovascular study, which is the Declare TIMI 58 trial, has not been completed. It is anticipated at least by April of 2019 and potentially may even be completed early if they reach their enrollment and based on the data that's available so far. Although we don't have our dapagliflozin data, it appears that this potentially could be an overall class effect for reducing cardiovascular risk with our SGLT2 inhibitors. The CBD Real trial was a multinational observational study that matched the initiation of SGLT2 inhibitors versus other antihyperglycemics. And looking at over 300,000 patients, they found that when they were looking at a population that was about 57 years old, only 54% males, so we now have a better representation of females, and 13% with established cardiovascular disease. We did see a number of these patients already on dapagliflozin, so although we don't have their individual trial, they have been represented in CBD Real. About half of the patients were already on canagliflozin, 42% on dapagliflozin, only 5% on empagliflozin. But as they observed these patients, they did find that there was a 39% decreased incidence of heart failure hospitalizations in the patients that were on SGLT2 inhibitors versus other agents. They also saw a 51% decrease in all-cause death associated with our SGLT2 inhibitors. So today, what does this mean for us? Again, potentially a class effect with our SGLT2 inhibitors, but we hope that that may be confirmed when the dapagliflozin data becomes available. Also, this is helpful to see in the CBD Real trial because only 13% that had the established history of cardiovascular disease. So this potentially is an indication that your patient doesn't have to have that established history, but be cautious when you are extrapolating that data out. Switching gears, we're now going to look at our GLP-1 agonists, starting with the LEADER trial. And this was looking at liraglutide, titrated up to 1.8 milligrams daily versus placebo in just over 9,000 patients. These people were all at least 50 years of age with diabetes and considered at high cardiovascular risk. For the LEADER trial, high risk was defined as a patient that was 50 years or older with a cardiovascular condition that could include CHD, cerebrovascular disease, EVG, CKD stage 3, or a heart failure diagnosis that was at NYHA stage 2 or 3. Alternatively, you could have an older patient, 60 years or older, with at least one cardiovascular risk factor, and that included proteinuria, microalbuminuria, hypertension, left ventricular hypertrophy, left ventricular systolic or diastolic dysfunction, or an achial brachial index of less than 0.9. So we do see that among these trials, although we say it includes patients with high cardiovascular risk, each trial defined that risk in a different way. For the LEADER trial, we had about 64% males around the age of 64 years. The average duration of diabetes was 13 years with a baseline A1C of 8.7%. 81% did have an established history of cardiovascular disease, so we do want to keep that in mind. These patients were followed for 3.8 years, and we see the primary endpoint was the time to first occurrence of a cardiovascular event, which included cardiovascular death, non-fatal MI, or non-fatal stroke. And that risk was reduced with liraglutide. When we look at the individual components, we also see that liraglutide was favorable, especially in cardiovascular death alone or MI alone, where it was statistically significant. Based on this data, the FDA has updated the label for Victoza, which is our brand name liraglutide specific for diabetes. As of August 2017, Victoza is approved to reduce the risk of major adverse cardiovascular events in adults with type 2 diabetes mellitus, and again, the key here, that have established cardiovascular disease. We have a number of other GLP-1 agonists available on the market, but I do want to take a moment to talk about semaglutide. This is currently awaiting an FDA decision for US approval, but it is on the European market. Semaglutide was studied in the SUSTAIN-6 trial, and we'll just briefly touch on this. It was just over 3,000 patients that had a history of diabetes and high cardiovascular risk. We see that they had 50% males, so a little better representation of females in this trial. And 83% did have an established history of cardiovascular disease or CKD. They had diabetes for about 14 years at baseline and an A1C of 8.7% at baseline. The primary endpoint was similar to our LEADER trial, looking at the time to first occurrence of a cardiovascular outcome. And there was a statistically significant difference between semaglutide and placebo that favored semaglutide. However, there is some concerning information that did come out of the SUSTAIN-6 trial because there was evidence that there was a potentially increased risk of retinopathy in our patients using the treatment. It's unknown if this is truly drug-related or potentially related to something else. Perhaps rapidly lowering the glycemic control in these patients has been proposed as a potential way that this happened, but we will continue to monitor this. There was a trend for this in the LEADER trial as well. So watch for additional data coming out. What about our other GLP-1 agonists that are on the market? We have quite a few at this time. Currently, trials have been completed for exenatide once weekly, which you may know is brand name Bydureon, and lixisenatide as well. In those trials, there was not cardiovascular harm, but there also wasn't cardiovascular benefit, which confirms that this is not a class effect. Trials are currently ongoing for albiglutide and dulaglutide, and that data is expected to be completed in March and July of 2018, respectively. So overall, what's important to remember is your key takeaways. Right now, all of the cardiovascular data in the new agents is for those with an established cardiovascular disease history or high cardiovascular risk. We don't really know the role in primary prevention in our low-risk patients. So if you're managing someone that's perhaps much younger and doesn't have additional risk factors, you cannot necessarily extrapolate this data to that patient population. Let's go back to Mr. Jones and decide if we can apply it to him. So we can see that history of diabetes with a history of MI. His A1C currently is at 8.2%, and he's managed on metformin alone. So what would we consider today to improve his glycemic control and also potentially improve his cardiovascular risk? Starting with our GLP-1 agonist, liraglutide could be an option. It's the only one currently available in the US that does have that established cardiovascular benefit, and it does have an FDA approval that matches Mr. Jones's description. Benefits of this agent could, of course, include that reduced cardiovascular risk, but also a little bit of weight loss is possible, and you may recall that his BMI was 31. Disadvantages include cost. It is brand name only at this time. It is an injection, so you'd want to appropriately educate your patient and be sure that they were comfortable with that once a day. And also adverse events. Primarily with our GLP-1 agonists, we are concerned about potential GI effects. Our other option to reduce cardiovascular risk would be an SGLT2 inhibitor. As of right now, Frozen is the only one that does carry an FDA approval, but keep in mind this may also be an overall class benefit. If you were looking at Frozen, you would want to evaluate Mr. Jones more thoroughly for his risk of amputation, making sure he doesn't have a history of peripheral neuropathy or PAD, that he doesn't have a history of ulcers or any current amputations as well. Benefits of this class, again, it's an oral agent once a day, so he may be more comfortable with that versus an injection. You do have the potential for a little bit of weight loss. And also it is associated with slight blood pressure lowering. And we just discussed not long ago that his blood pressure potentially is a little bit above goal. So by adding one of these agents, we may actually be able to lower his blood pressure without giving him an additional antihypertensive agent. Disadvantages, we also want to consider cost for this group as well, being brand name only, and also potential side effects. We would want to be sure that he stays really well hydrated, especially as he's older, so that we can reduce the risk of his volume-related adverse events like dizziness and hypotension. We would want to educate your patient on the potential for UTIs and his genital mycotic infections. Although they're more likely in females, they can occur in males as well. And at the end of the day, we do want to continue his metformin. We did determine that his renal function is good right now, and metformin would be considered safe as long as he's not experiencing any adverse events. So we will use the metformin in addition to another agent. So with that, we are now going to transition over, and Dr. Olin is going to join us to talk about the concentrated insulin products.
Thank you, Dr. Batise. Thank you for educating us about ways to reduce cardiovascular risk factors and optimize care for our patients with diabetes. Now we're going to change gears and talk about some of the newer insulin products that are available, again, to help optimize care for our patients with diabetes and to make some issues more convenient for patients. To start off this section, I would like us to keep a case in the back of our mind. Let's think about Ms. Jones. She's a 54-year-old female who is just now being discharged from the hospital after a 3-day length of stay for treatment of pneumonia. Her medical history is significant for type 2 diabetes, stage 3 chronic kidney disease, hypertension, and dyslipidemia. With respect to her diabetes, her medications include metformin twice daily and NPH insulin 90 units subcutaneously twice daily. During her hospital stay, we found out that her A1C was 9.5, which suggests to us that there's some room for improvement. As I go through some of the newer concentrated insulin products, keep in the back of your mind these questions. What are Ms. Jones' glycemic, lipid, and hypertension goals? You can think about those based on what you just learned. And then putting our whole presentation together, think about what therapeutic alternatives alternatives may improve both her glycemic control and her overall outcomes to improve her health. Concentrated insulins. When we talk about diabetes in the United States, we really primarily tend to think about type 2 diabetes. When we think about people that have diabetes, 95% or more of those individuals have type 2 diabetes, which is characterized by insulin resistance and relative insulin deficiency. Per the CDC statistics, about 7.2% of the United States population has diagnosed diabetes. When we look at those people that are adults with diagnosed diabetes, over 85% or 87.5% of these folks are overweight or obese. Being overweight and obese contributes to insulin resistance. So we have a large patient population that has diabetes and that is overweight. Our guidelines, both by the ADA and AACE, recommend initiation of basal insulin in individuals that have symptomatic hyperglycemia and that have A1C of at least 9 or 10. So because of the large numbers of patients with diabetes and with obesity and that have insulin resistance, there really remains to be a continued need for safe and effective insulin options. And we've seen that our insulin doses are getting larger and larger. Because of this continued need, additional concentrated insulins have become developed to help improve absorption of insulin and to minimize some of the larger injection volumes that have been necessary for our patients that are more insulin resistant. One new product that became available is, we're already familiar with insulin glargine in the 100 unit per ml formulation. This year, a 300 unit per ml formulation of insulin glargine became available, brand name Toujeo. With these newer insulin products, we want to be sure that they demonstrate similar efficacy to the insulins that we have available, because we want to make sure that we have a consistent level of glycemic control, but we also want to not have any worse outcomes in terms of adverse effects either. So the clinical trials for these agents, we evaluated the efficacy in terms of A1C lowering, and then we also looked at rates of various types of hypoglycemia to ensure that we weren't having any safety issues. The clinical trials for the U300 were the Addition series. There were 4 clinical trials evaluating participants with both type 1 and type 2 diabetes, where U300 insulin was compared with U100. Through a number of these Addition clinical trials, A1C lowering was similar over a 6-month period. And then with the U300 insulin, we saw lower rates of confirmed or severe hypoglycemia when compared to U100 insulin glargine. A meta-analysis of the Addition clinical trials was published by Ritzel and colleagues, and that reference is at the bottom of the slide. So compared with U100 insulin glargine, we have similar efficacy and maybe a little bit better safety. Duration of action is at least 24 hours, which allows for once daily dosing. Important to note that with the U300 product, the maximum dose per injection is 80 units. For your patient requiring a dose that's larger than 80 units, they will need to give multiple injections. Open and use storage is 42 days outside the refrigerator. When we need to know about conversion between insulin products, be aware that we can convert doses 1-to-1 from U100 insulin glargine or Detamir. However, if you have a patient that's currently maintained on NPH insulin, a 20% dose reduction is recommended when transitioning from NPH to U300. One of the Addition clinical trials, Addition number 4, showed that a higher dose of U300 may be needed compared to U100 ultimately. Therefore, it's very important to continue to monitor your patients for both efficacy and safety once these insulin conversions have taken place. Our next concentrated insulin is a completely different molecule, and this is also a basal insulin, insulin degludec or Tresiba. Important to keep in mind that both the U300 and the insulin degludec that I've been talking about, these are both basal insulins, meaning that these are your longer acting insulins meant to maintain glycemic control over the course of the day. So you see that these basal insulin products are dosed usually once daily. Insulin degludec has some differences in pharmacokinetic properties that allows it to last longer within the body. Many more clinical trials were done to establish safety and efficacy of degludec, with the wide majority of them being comparing degludec to U100 insulin glargine. To summarize those clinical trials, the extent of A1C lowering was non-inferior to insulin glargine, and there were lower rates of hypoglycemia in both insulin naive and in patients with previously treated type 1 and type 2 diabetes patients. The beneficial effect on hypoglycemia was also observed in the switch clinical trial series, where you had participants on both U100 insulin glargine and then transitioning over to degludec. A recent study that's been published by Marceau and colleague, also the DEVOTE trial, had the composite cardiovascular outcome of cardiovascular death, non-fatal MI, or non-fatal stroke, demonstrated that degludec had non-inferior cardiovascular risk compared to insulin glargine. So that way we're not adding any additional cardiovascular risk, or that it's not any worse than what we already have. Duration of action for degludec is 42 hours. For those patients that maybe miss a dose, this gives us a little more wiggle room, but it is generally dosed once a day. The maximum units per single injection is 160 units per one dose. Also need to be aware that degludec is available in a 200 units per ml product, so a more concentrated insulin than what we're used to, but it also is available in 100 units per ml formulation. So make sure that you and your patients are clear about which product that they're receiving and that the dosing is consistent. Storage requirements are listed. Recommendations for switching between different insulin products is 1-to-1. U500 insulin. This is a unique insulin. It's been around for a long time, and it has both basal and bolus insulin characteristics. So it does have a short-acting mechanism of action, and patients that use U500 insulin, it is really meant to cover both their basal, meaning their long-term throughout the day, and their bolus, meaning post-meal insulin needs. Data with U500 insulin has shown similarity in A1C reductions in a 3 times a day versus a twice-day regimen, which allows our patients to have more flexibility in terms of how to give themselves U500. When they looked at hypoglycemia, this particular study showed us that non-severe hypoglycemia events were lower with 3 times a day, but when they looked at severe hypoglycemia and weight gain, there was no difference whether patients were using 3 times a day or twice daily regimens. This information really gives us a lot of flexibility to help design appropriate regimens individualized for patient needs. Big caveat with U500 insulin is that it's only FDA indicated for those patients requiring at least 200 units of insulin per day. Its duration of action is shorter than the other insulins that we've talked about, again, and because of that, it has basal and bolus characteristics. Maximum units per single injection is 250 units. This gives us a lot of wiggle room so that patients don't have to give their single dose in multiple injections. Fortunately, these days, U500 now is available in a 3 ml pen, so we hopefully will lead to much more ease of administration. The multiple dose vial is still available as well, but we also have new syringes available that we don't have to do the dose conversions with the older syringes that we used to have to do. So really big ways that have improved patient safety. In-use storage, 28 days at room temperature. Important to note for U500 is that we want to administer the dose 30 minutes prior to meals so that we can maximize those bolus insulin effects as well, where the other insulins don't have to be given, the other insulins that I've talked about don't have to be given with respect to meals. When converting between other insulins and transitioning a patient to U500, we need to consider what the patient's A1C is at initiation of U500. If we're starting off with a patient that has an A1C of greater than 8, we would start the total daily dose of U500 at 100% of their total U100 total daily dose, or their total daily dose, or if the patient is also on a bolus insulin, that would be added into it as well. If the A1C is less than 8 when we're starting U500, we would start their new U500 dose at 80% of what their previous total daily dose was. Bottom line, we need to consider where the patient is at glycemic control-wise before transitioning to U500. To recap, insulin glargine, insulin degludec were new basal insulins now in concentrated form. U500 has basal and bolus insulin characteristics. We also now have a bolus insulin that comes in a more concentrated form. Insulin Lispro or Humalog now is available in a 200 units per ml formulation. Its safety and efficacy was demonstrated in a study that showed bioequivalence between the U200 product and the U100 Lispro product in patients without diabetes. So we know that it at least is similar to the Lispro 100 units per ml product. It has a short duration of action because it's a bolus insulin, and this product really gives us a way to help minimize the number of injections for those patients that require bolus insulin at larger, that end up requiring larger injection amounts. Now that you've learned a little bit about the concentrated insulin products available, let's go back to Ms. Jones to recap some of what we've learned today. Ms. Jones was discharged after pneumonia. Her diabetes meds included metformin and NPH insulin, 90 units subcutaneously twice daily. Her A1C of 9.5 suggests that there's further room for glycemic control. Hope you thought about her glycemic, lipid, and hypertension goals as I was speaking. As far as glycemic control for Ms. Jones, we have to consider individualized patient factors such as whether she was having, how much difficulty she was having with the NPH insulin, what degree of hypoglycemia tends to affect her. We also need to consider the impact of her comorbidities such as her hypertension and her stage 3 chronic kidney disease. Based on the information that you have, a A1C goal of 7 to 8 certainly would be reasonable for Ms. Jones. You learned about the various guidelines for lipid control for Ms. Jones. Just having diabetes alone puts her at a need for likely needing a moderate intensity statin. When we consider her stage 3 chronic kidney disease as a potential risk factor for cardiovascular disease, and if she has a high LDL at baseline, her moderate intensity, there may even be an opportunity to increase it to a high intensity statin just to help improve cardiovascular outcomes. As far as hypertension or blood pressure, we would like to see her be at a minimum of less than 140 over 90 millimeters per mercury, or if we think that she has a higher degree of cardiovascular risk due to her comorbidities, you may even be able to argue for a more intense blood pressure goal. What therapeutic alternatives may improve her glycemic control and outcomes? She is receiving NPH insulin 90 units subcutaneously twice daily. These higher concentrated insulins may give us an opportunity to have her just have to give one injection a day. We certainly can consider changing her to insulin degludec, which would allow for 180 units per day for one injection. She's not yet a candidate for U500 because she's not at this point in time receiving greater than 200 units per day, but as we begin to titrate her dose, she may become a candidate for U500. As far as the U300 insulin glargine, that is an 80 unit per ml max, or 80 unit maximum injection per injection. So she would end up having to use multiple injections for the U300. So insulin degludec may be a reasonable alternative for her to change to. We also learned about other agents that may potentially reduce her cardiovascular risk. The SGLT2 inhibitors, unfortunately, she's not a candidate for them due to her stage 3 chronic kidney disease. We also learned about liraglutide, which may reduce cardiovascular risk in patients with established cardiovascular disease or cardiovascular risk factors. And that would be a conversation to have with her physician whether she meets the criteria. Of course, depending on whether she's overweight or not, there may be a weight reduction benefit. Bottom line, there are all kinds of strategies now to help improve outcomes for our diabetes patients than ever before. And it's really part of our role as a practitioner to help our patients find what methods that they can do to help improve their outcomes and help maximize their care. We want to thank you for your attention through this session. We have enjoyed providing this webinar for the North Carolina Association of Pharmacists. We hope you find this presented information to be helpful. To receive continuing education for this session, please follow the instructions provided alongside the link to the webinar on the NCAP website. Thank you for your time today.